So there's a rapidly shifting healthcare landscape, which we're all aware of, and healthcare systems, which have not been on the forefront at this conference so far, are vitally critical because that's how most of the implementation is going to take place. They have to be nimble, creative, they've got to provide accessible, high-quality care, but at the same time, they have to figure out how to get paid because reimbursement models matter. Two of the visionaries reimagining the future of healthcare are Robert Garrett and Kelby Krabbenhoft, both of whom I've gotten to know, and both of whom are going to be able to educate us in a I think, fairly interesting way about what the opportunities are out there. And understanding this part of the model will make all the things you've heard so far at this conference that much more actionable. Thank you both for joining me.
Thanks. Thank you.
So technological advancements clearly fast, moving. We've been hearing on this dais about a bunch of ideas that are transformative. How have your two individual systems, one closer to an urban area, working closely with large insurers in the tri-state area around New York City, and the other based in the Dakotas, but remarkably influential as a model of how this can be done right. How have both of you innovated in your practical applications of all this technology to make the care of the patients in a rural and urban area more effective?
Should I start? Okay. First, I just want to say it's a real privilege to be here. This is my second Vatican conference, and I'd like to thank Dr. Robin Smith. I'd like to thank the Pontifical Council and the Cura Foundation. This is amazing, and great experience, and we're certainly looking forward to the audience with the Holy Father later today. So, in terms of innovation. I like to think that innovation is in our DNA. We've made it the centerpiece of our culture at Hackensack Meridian Health. So you heard yesterday a little bit about the innovation, the partnership between IBM, Coda, and IBM, Watson, and Coda, where you're really marrying up big data with precision analytics to really give clinicians, physicians, and other providers the tools to really transform care. It's already being done in cancer. We're planning to roll that out also in other disease entities like diabetes and behavioral health. I think it has some real potential. The other thing that we have done is we've struck up a partnership with the New Jersey Institute of Technology, and we have created an innovation center where we're encouraging frontline employees, physicians, community members to put forth their innovative ideas. We also have established a $25 million innovation fund where we can invest in new startups, and that's really it's quite an extensive process. And we actually even have a panel of judges, kind of like Shark Tank, except our attorneys said we couldn't name it Shark Tank, so we call it the Bear's Den. So if we like your company and we like your product or your service, we're warm and cuddly in the Bear's Den. If we don't, we kind of chew you up. But we're already planning to invest in our first product, which is a wearable device for patients that have congestive heart failure, and it will be able to track patients, monitor their vitals, et cetera. The other thing I wanted to just mention just quickly, because we haven't really talked at this conference about patient experience. So we have some technology in the area of patient experience that I think is really making a difference. For one thing, we have a GPS tracking system that helps patients and their families navigate their way through our hospitals and our healthcare system. And a lot of hospitals are like mini cities, so that's really very, very important. We also have a partnership with NRC Health, which gives us real-time data from patients while they're in the hospital. So these patients receive email or texts or even phone calls, and because of that partnership and because of that technology, we have tripled the amount of actionable items that we can actually act upon while the patient is still in the hospital. So there's a lot of innovation going on. As I say, we like to think it's coming from the ground up. And some of the strategic investments we're making, I think, will certainly lead to some real changes in practice.
Why Bear Den? Why not call it the snake pit or the lion's lair?
We thought of the snake pit, actually. I don't know, Bear's Den has a little better connotation.
But there's a caduceus, there's a snake in it. It would be obvious for medicine. All right, Kelby, do you have a similar organization? What do you call yours in the Dakotas? The wolf?
Sanford does the job. But, Mehmet, you know this, but maybe the folks in the audience was gracious and happy to be here 2 years ago. Same invitation. Thank you, Cardinal Ravasi, and Robin and everybody, thank you. This is an incredible opportunity to see what's possible, and then it falls to people, I think, in this segment, how are we going to deploy it? How are we going to make the wonder of a blind child who sees again relevant to 700,000 children? How do we execute? How do we bring that to everybody? And in the Dakotas, as you said, we're primarily based there, but because of acquisitions and consolidations going on, it's really from Hawaii to Florida and all points, and even here in Europe and elsewhere. But it starts with us by saying, what do we need to be, and what does have to be accomplished in the next decade? And that's how we structured ourselves. It started with physicians that would set the standard of our quality and the very essence of the care we provided. Quickly went to the rest of the employees that are bedside. But then we included 20 years ago, anticipating that someday we would have to bear risk and know the financial side did have to eventually connect to the clinical side in a value proposition. We started our own insurance company. And Mehmet and I have talked about this quite a bit, because that's where the synergy, and not the lines being drawn, but the lines being blurred now. And I think new friends, new allies are being formed around that. So with the institutions providing the clinical care, with the insurance bringing the financial aspect to provide ultimate value and cost consciousness to the table, always cognizant of physicians setting the standards for us. That's how we deploy healthcare across our region. And it's a little different. We measure our market in terms of square miles, and it's about 300,000 square miles of our primary care area, a little bit like getting around Alaska. There are more buffalo and cattle than there are people, but we're the second largest insurer in that region, so it's very relevant. And it's always great, like-minded CEOs like Bob and I can get together around the same kind of ideas and yet represent such different demographics and geography.
There's been a clear move in the United States away from volume-based care, which is how I was trained. I don't know in Europe how this transition is happening, because it's already a bit more of a value-based system. But the fact that it's moving towards value seems to put more pressure on possibilities like prevention, keeping people out of a hospital.
Absolutely.
We've heard a lot about technologies that could help with this process. How is it actually influencing you in the trenches?
Well, what's real relevant again for us, and it's day-to-day practice now, is that we are able to take the premium, just like an insurance company, and then apply it to healthcare in a way that innovation is our friend. It used to be the longer we could keep you in the hospital or the more procedures we could do on you, that was our economic opportunity. But today now, what you're hearing in the audience and what you're hearing across the world from this stage in terms of innovations, stem cells, genetic therapies, these are the things that can replace a $50,000 shoulder surgery for Jack Nicklaus and instead turn it into a $10,000 event. That's really important for an insurer, but when you're the provider and the insurer, now you can maximize that opportunity by going to the patient, talking to them about those alternatives, and the end product is a value proposition that you described.
Not to hijack the conversation, but stem cells and stem cell clinics are one of the biggest, ripest areas for fake advertising and news in the United States.
Yes.
There are a couple, I can probably count them on two hands, really high quality centers like yours that are doing cutting edge work on stem cells. There's 900 plus centers that don't do that the right way, and they pervert the system. So everyone thinks stem cells can do everything this year, but next year they'll know it can't do anything. They'll know it because they've been conned paying lots of money for Alzheimer's cures of stem cells. So when legitimate businesses are investing hundreds of millions or more dollars to do stem cell research, you won't be able to market your products because you'll be in a tainted neighborhood, a polluted neighborhood.
So the journey to value is really happening all across the country. So in our market, it's not as advanced as in other markets. About 25% of our revenue is value-based, but we expect that to ramp up significantly. So we're actually changing our entire organizational structure, and we are reorganizing what we're calling around care transformation and around care transformation teams. So what we're doing is we're taking each major disease entity and really looking at the care pathway. We're looking at the processes that are applied to providing that care, and we're really revamping it. And through our partnership with New Jersey Institute of Technology, we've hired engaged engineers. We have process improvement experts that are on board, and we are literally taking apart the process for each disease entity. And then what we're doing is we're creating a bundle of care, and getting back to Kelby's example of where this comes in on the insurance side. And because we're providing the value, we're actually providing more efficient care by revamping the processes through care transformation, and we're producing better quality outcomes. This is really an attractive bundle where we can contract with insurers, and we actually have a pilot program going with Horizon Blue Cross in New Jersey, where we're contracting on these bundles of care. We believe this really is going to be the future and will really produce the best outcomes for us to prepare for value. The other piece I just wanted to mention quickly is that we were an early adapter of the Accountable Care Organization when the Affordable Care Act was passed, and we actually have one of the more successful accountable care organizations in the country. I think it was ranked number 3 this past year based on the quality outcomes and based on money that's saved. This past year, as an example, it saved $50 million for the system on Medicare patients. We think that ACO experience in really managing the senior population will enable us to get into the Medicare Advantage space in the future and potentially do our own health plan or joint venture with an insurance company for Medicare Advantage. It's really been kind of, I call it like the training wheels to prepare us for Medicare Advantage. And obviously we're expecting a huge increase in the senior population between now and the year 2050. They're expecting the senior population in the U.S. to double. Although when I heard about life extension yesterday, I think it may actually triple based on what we heard.
Hopefully. Medicine is a very labor-intensive field, and the jobs are often wonderful ones for well-meaning people who contribute to society, but technology is going to dramatically change the workforce within healthcare. How are both of you preparing for that in your organizations? And just if you can, update us on how many folks report to you. These are gargantuan numbers.
As of yesterday, some work that was done moved Sanford from about 30,000 employees to 50,000. So you're right, it's a big labor undertaking, and between these things and bedside little larger versions that are just as portable, we find ourselves just totally swimming in the field of technology and innovation, not only for the caregiver, those 50,000 people, but for the patients as well, who access that immediately with the caregiver and follow their care through it. So the good news about this technology, and I was listening to your conversation earlier about fake news, is it's everywhere and everyone has access to it. There's not a lot of technical sort of primacy that we can gather and hold on to and uniquely hold. It is immediately dispersed throughout the population, and so we have to be not only ready to deploy on that front, but we have to be ready to understand that it's not a competitive edge. It's something everybody uses and everybody has to exploit to its full potential.
So we have 33,000 team members at Hackensack Meridian Health, and I believe in terms of the innovation and technology changes that are going on, it really starts during the educational process before we actually hire the employees. So we have many relationships. We have partnerships with nursing schools. We have partnerships with allied health schools. And what we're doing is we're working through those partnerships to change curriculum to really match what healthcare providers, healthcare workers are going to need to know in the future, particularly around innovation and technology. And then one exciting thing that you'll hear a little bit more about this afternoon is our new School of Medicine. So what we're doing is we're able, it's unusual to be able to start a new school of medicine from scratch. So we're taking advantage of that, and we've really developed a very innovative curriculum that will really teach doctors of the future about some of the new technology, about the innovation that's going on, about how team medicine really produces better outcomes. You'll hear a little bit more about it from our founding dean this afternoon, but I do believe it starts in the educational setting, and then we have a very extensive onboarding process, and some of the new technologies, the innovation that is occurring throughout our health network is discussed during the onboarding process. And then we actually have retraining. As technology comes in, we have to re-educate and retrain, as an example, patient care technicians in the ICU setting when we implement EICU technology. Those folks, intensivists, have to be retrained.
One of the big debates happening around the world is consolidation. You just had a little mini consolidation, not so mini. Two of you joined together, we have 83,000 people reporting to both of you. There's some benefits of that, and there's some potential risks. And there's been lots of outcry that it takes away some of the competitive elements that people find beneficial in healthcare, that it might take your edge off a little bit. And yet there are economies of scale, clearly other benefits from being able to take good ideas, best practices, and spread them. Overall thoughts on consolidation?
Well, I think both of us have been pretty busy about that issue as the leaders of our organization, and at least from my standpoint, the premise of the analysis is flawed because it's price sensitive, as though people today walk into our hospitals and buy a cholecystectomy or buy a shoulder repair per unit, per price, like you would buy bread in a grocery store or a car. It'd be more akin if you could buy insurance annually for food. And then you would go to various grocery stores and pick out what you need within the benefit plan of your food insurance. It's a very similar thing. And so price sensitivity per unit is really a misnomer, but that's where consolidation analysis is done in the regulatory environment in the United States, is premised on that. And our ability through consolidation then to somehow, for some reason, be angry or be negative toward the people that pay us, which are large insurers. It's oxymoronic. We wouldn't do that. We depend on them and we need them. And so what exists instead, we believe, is to try to project into the future, Mehmet, 10 years, 20 years, what will the regions of the United States look like, in this case, in terms of how we get paid? The government is a price dictator. They are not a price taker. We could tell them what we want, they're not going to take it, and they're our largest payer. So, same with so many Blue Cross Blue Shield plans, which is dominant and giant, and we're the second largest insurer in our states, but Blue Cross Blue Shield is the largest, and so we revere them and we work with them very closely. But at the same time, we don't sit and talk to them about a price per unit. We talk to them about the annual benefit package their subscribers get, what they pay for that, and how we can make that the most valuable for them. I hope that makes sense, because this is very complicated, and people want to buy healthcare based on a diagnosis or a price per element of service, but that's simply not the way it's done. It's not how Americans consume healthcare.
So my thoughts on consolidation and does it drive up pricing? I think it has in some markets. I think that's certainly factual. It doesn't have to, though. I think when consolidation is done for the right reasons, the right strategic reasons, it can actually make the health system and the health environment more cost effective. So as an example, in our case, we had a big merger between our legacy organizations, Hackensack and Meridian came together. Each one really brought something unique to the table. So Hackensack was known for its nationally recognized clinical care, a growing research infrastructure, this new medical school coming. But Meridian had this continuum of care, 450 patient care locations throughout New Jersey. So both sides brought something unique to the table. We were able to then marry the two up and reach some synergies. And we actually identified about $200 million of cost savings based on the efficiencies we can achieve by coming together. And that's something that we're going to be implementing over time. So I think if it's done for the right reasons, not just done for the sake of getting bigger, but if it's done for the right strategic reasons and there truly are benefits that each party can bring to the table, I think it can be effective in actually lowering a cost and making healthcare much more affordable. The other piece I would say is some systems have come together and they really haven't integrated. And I would call them confederation of hospitals. They're together under one parent organization, but they don't really operate, together in an integrated manner. Where systems have integrated, there's been true savings, there's been true efficiencies, and there's been better quality of care. So I think that's my other piece, would be making sure that it's done for the right strategic reasons, where both parties add something very valuable to the table, and also where there is a commitment to integrate.
So Bob and Kelby, you're both very innovative. So let me ask you a question that an innovative leader would want to address. With rising costs, it puts pressures on operating margins. Companies complain. It makes us less competitive. We all agree with that. If you were to get paid less money, because the government, in your case, Kelby, and it's true probably at Hackensack as well as the major payer, decides we're going to ratchet down expenditures with the hope that it drives efficiency. What are the other sources of revenue that you guys can rely on to keep your businesses efficient, high-quality delivering organizations, but take a little less of the money that may be given to you?
Real quickly, we were about a $4 billion company 2 years ago. Now we're, as of today, about a $6 billion company. And we set a goal at $4 billion, the math was easier, that 25% of our revenue would come from alternative sources, innovative sources. And we've been about the business of, you saw Dr. Alt here, who has a company in Generon. We took a stake in that so that we can be part of the stem cell revolution. We took stakes in various other subsidiary companies that are off the beaten path from the traditional care that we're known for in healthcare. But most notably are two things: our world clinics. We now have 35 clinics worldwide as part of the initiative of Mr. Sanford, who came and spoke here 2 years ago. And we're hoping through that to do not only charitable, appropriate care where there is not primary care, but also to demonstrate that these are sustainable economic and business solutions to worldwide delivery of healthcare. And so that's one that we think is going to grow a revenue source for us, achieving that $1 billion target. But the most successful one has been our profile diet. We're now, in the next 3 to 5 years, we're already opening, we have 35 stores. There's 151 going online in the next 3 years. It's a plant-based whey product for protein. Subscribers have lost over 1 million pounds. It's an incredible thing. I've lost 80, and it's oh, but
It looks like a gazelle now.
but those are the things that we think innovatively we can combine a strategy about providing healthcare and innovation for the future, but also have something that creates a value to the organization and those that are becoming part of us.
Kelby told me back in the green room that if this panel goes well, we might get the exclusivity for the diet in New Jersey.
Yeah, that's right.
Very nice. It's been very impactful.
If this goes well.
Well, Bob, he looks like you look like a greyhound already, so I'm not sure it's going to change much.
But in terms of alternative sources of revenue, so today, Hackensack Meridian, about between 85 and 90% of our revenue still comes from the hospital side of our network. But we have invested heavily, as I alluded to before, in outpatient ambulatory care facilities, 450, as I said, across New Jersey. So through partnerships, I expect the revenue base to grow in these businesses. They include retail health clinics. They include urgent care centers, ambulatory surgery centers, fitness and wellness centers, assisted living facilities, post-acute care facilities, nursing homes, subacute care facilities. So I would expect as more and more care is delivered outside the four walls of the hospital, that revenue base from those alternative sources will grow significantly.
Let me finish up talking about practices of physicians that are more and more linking up, aligning with large healthcare providers, because They're fearful of being left behind. They need infrastructure support. They know you can help advance that. But oftentimes, it can create some non-aligned incentives. So what are the optimal number of lives to be served by a healthcare system? Is there a number like that?
Yes.
Go ahead. I want to hear what that number is.
Yeah, I know.
Kelby gave the first
Good
half
luck,
of the
good luck
answer.
with that.
Bob takes
You
the
got-
second.
Again, we look at our region, and it's completely different, but the similar math applies. You've got so many thousand employees, usually somewhere between 1,500 patients, between 1,500 and 2,500 patients that can generally, on a generic physician, but we talk in terms of primary care, that is the panel of patients that we have to do that generalized math to. It's very difficult because a cardiologist or a neurosurgeon is going to see a much different subset of the population than a primary care physician. We have about 1,500 physicians today. We would expect somewhere around 2,500 over the next decade to meet the needs of those that come to us and say, can you take care of our retirement system? The Medicaid population, the Medicare population. We have to be ready with that infrastructure to do it. And then the complicated business of compensating those physicians, incentivizing those physicians, and making all those things hone in on providing the highest level of care to the satisfaction of the buyer and that patient is really a difficult matrix. But after you do it for a while, you can figure it out, and the physicians help you get there.
Right. My philosophy has been that one size does not fit all. So we have private physicians, we have employed physicians. What we're doing, there's 8,000 physicians affiliated with Hackensack Meridian. We've established a clinically integrated network, and all comers are welcome. Whether you're a private physician, you're an employed physician, you can align with our health network through this clinically integrated network. And some of the benefits could be that you get a significant discount on your electronic health record in your particular office. You'll be able to participate in value-based and risk-based contracts with the health system. And out of the 8,000, we just started the clinically integrated network about a year ago. 3,500 have already engaged, have already signed up as part of this. So we think that's the way that we're going to get alignment with physicians. I don't know what the right number is in terms of number of covered lives, but that number seems to, the predictions seem to grow each year in terms of what we're going to need.
I'm going to applaud you both very much. You see why these two gentlemen are revered as leaders in the future as well as today. Bless you both.
Thank you, Mehmet.